Non-invasive advanced respiratory support, or NARS, is a treatment that delivers pressurized air and oxygen to support people in acute respiratory failure. It comes in two forms: non-invasive ventilation, which delivers 2 levels of pressure, and continuous positive airway pressure, which delivers a single pressure throughout the breathing cycle. NARS saves lives. It has strong evidence base in decompensated COPD, and many patients need it repeatedly because their underlying conditions fluctuate over time. But at the end of life, NARS becomes ethically and emotionally complex. The mask is tight, the alarms are loud, and the treatment can be frightening. Yet for many, it also symbolizes hope. The possibility of one more recovery. What we understand far less is how the machines themselves shape decisions. When NARS is started, when it is continued, and when clinicians recognize that someone is dying. To explore this, an ethnographic study was carried out in a large UK hospital. Over 108 hours of observation and 14 patient journeys. The study examined how clinicians, patients, and technologies interact. Using field notes and composite narratives, the study aimed to answer the question: how is dying produced through everyday clinical practice? 2 theoretical lenses helped illuminate what was observed. First, Foucault's concept of power knowledge. Foucault argues that authority isn't simply held by the most senior person, but by those who wield sufficient power knowledge. In respiratory care, the power to declare a patient is dying rather than critically ill isn't just clinical expertise. It's negotiated, relational, and often contested by people who hold differing amounts of power knowledge. The second theoretical lens was Orlikowski's theory of technology in practice. This perspective helps us see machines not as passive tools, but as actors woven into everyday routines. The machines structure time, direct clinical attention, and produce data, especially blood gases, that carry significant importance. In practice, the machine begins to act. It demands adjustments, prompts medication, and shapes decisions about whether treatment is working. When combined, these lenses show how technology, clinicians, and institutions co-produce truth, including the truth of dying. 3 central findings emerged. First, fractured authority. Clinical authority split between daytime and nighttime. Senior consultants made plans during the day, but junior doctors were often left to enact or revise them overnight, frequently in isolation, without specialist support, and under intense moral pressure. Their decisions were later scrutinized, not because they were necessarily wrong, but because they lack the power knowledge to legitimize them. Second, care intention. Once NARS was started, care reorganized around the machine. Patient distress was often addressed only when it interfered with mask seal or ventilation pressures. Blood gases, printed on small curls of thermal paper, became privileged forms of evidence, guiding decisions more strongly than the patient's embodied experience. As patients deteriorated, different clinicians recognized the transition from ill to dying at different times. Throughout this period, tension grew between the needs of the machine and the needs of the patient. This tension was released only when a decision was made to provide palliative care. When the machine left the clinical space, power knowledge shifted from respiratory specialists to the palliative care team. The focus of care became enabling a death free from technology, where the patient's needs came first. Third, faith in the machine. Staff often describe NARS in near ritual terms, a Deus ex machina capable of dramatic last-minute salvation. Many recalled patients who had recovered unexpectedly, reinforcing a fear of withdrawing the mask too soon. Even when a patient appeared to be dying, another blood gas was often sought, a final consultation with the machine, even if the result no longer influenced care. This faith shaped the language of care. The machine was always described as working, but sometimes the patient failed to recover. Such faith occasionally prolonged treatment burden and delayed transitions to comfort-focused care. This study shows that recognizing dying is not a straightforward clinical judgment. It is an emergent, distributed achievement shaped by machines and people. Improving end-of-life care with NARS requires more than new policies. It means attending to the material infrastructures that shape decision-making, supporting junior clinicians who shoulder moral labour at night, and critically examining how machine outputs come to dominate clinical truth. Ultimately, medicine's task is not only to forestall death, but to engage with the qualities of living and dying. Understanding how technologies like NARS reshape these boundaries is essential if we are to provide humane, coherent, and compassionate care at the end of life.